Well, thank you. It's so nice of Trelog to invite us and to introduce me so kindly. I'm so thrilled to see all of you in this room, and I'm really just going to build on what Shannon and Haiwen have already taught us about large language models and talk about some work in skin cancer detection that I'm very involved with. And I'm really going to talk about two major challenges. The first challenge is about data. So we have heard so much today about where AI models can help us. You know, it can help us schedule patients. It can help us understand, what's going on in clinical practice. But our data, especially in the United States, is still all over the place and completely disorganized. And, I'm just giving an example from my own hospital. This is just a text message, what's going on? 44-year-old, been there for a while. What is that? And this is a better quality image than most primary care doctors give us. I'm really worried, needs to see a dermatologist. So I see this in clinic, yellow. I decided it needs a biopsy. This isn't a dermoscopy talk, so I'm just gonna go to, oh my gosh, this patient actually had a recent CAT scan and it's actually on there. I don't know if you all can see it right at the bottom. I have no pointer. It doesn't matter. Anyway, oh, maybe I can point with my, oh, it's right here. So then you see there's a recent CAT scan. It's actually a really large lesion. And so this ended up having an incisional biopsy rather than a biopsy in clinic. It's a growth path photo. It's a DFSP. So if you look at all the media that we just consumed over the past like 10 seconds, we have the photo from the primary care office that was sent to me by text message, which you're not supposed to do. I also acquired a photo. We had this old CAT scan where we could find out that this was actually a tumor rather than a superficial lesion that you could just see. We have growth path and we have histopath. And in most systems in the country, these are all in totally different places. There's fewer than 4% of even hospitals have a integrated enterprise system that includes dermatology. And, outside of large hospital systems, these photos are wherever. So we've been talking so much about multimodal and trying to incorporate so many different types of images into AI. And we can't, we don't even have these all in the same place. So we do have to talk a lot about how to ethically and with privacy protections get to this state, because maybe, in that CAT scan, actually, the superficial skin wasn't even commented on. And so that tumor wasn't even seen. And that's not even the radiologist's fault. That was probably a CAT scan for a lung pathology or for something else. They don't even look at the soft tissue. And that's the kind of thing where maybe if we had more integrated systems and we had more AI models that worked on multimodal data, we might be able to do a better job. So I like to talk about this case for so many reasons. I think it's a great use case for a lot of the things that we've talked about today. And it really highlights one of the main problems that we have, which is we have so much great data to test our algorithms and to train them, but it's all over the place. And one of our jobs as dermatologists is to advocate for this type of data to become better annotated and to end up in the same place. And one of the things that we've been trying to do at MSK is to at least link some multimodal data with structured information. So most places don't even have the dermatology photos in the same place as the pathology report, because your photos may or may not be in your electronic medical system. That's something we've been working on a lot, and to try and keep billing and pharmacy in that same place so you can do longitudinal assessment of lesions over time. Okay, so I'm going to build on what Shannon just told us about considering a model in your practice. So assuming you actually have access to the data that will feed into an AI model, which a lot of times places don't have. We worked with the International Skin Imaging Collaboration a while ago. This is an old list, and there's a bunch of new members of the community here. So I'm going to update this to come up with a checklist. And this has exactly the same things that Shannon talked about, but there's also more examples outside of large language models for data assessment. One of the things that I wanted to talk about here, so I wrote into Gemini, like, can you get me an AI scribe? And this is what an AI scribe looks like according to Gemini. So what is the model trained to do? And for large language models, that's really broad. It's trained to provide predictions about the next word in a sentence or image-based descriptions. But we know that this is going to fail if it goes outside of that training. We talked about technique a lot. I wanted to also add for skin cancer detection, a lot of models are not using histopathology as a gold standard. And for melanoma, we know that even one single histopathology read may not be the same at one center as another center. So obviously, we should not have our AI models read by a teddy bear. That also is a Gemini request to create a melanoma histopathology image, which most of us in the room will know that this is not a melanoma histopathology image. There's a long way to go with respect to what we really know in terms of the large language models and especially their expertise in dermatology. Very common medical scenarios may be very, very obvious to the best medical language models out there, but dermatology is still a unique specialty and we need our own evaluation, just as Shannon described earlier. Technical assessment, I was so excited to hear your large language model assessments. It's so creative, but we all have different practice areas and we are all practicing in a different place. And so knowing whether it will work where we practice for this distribution of our patients is going to be really important. And I've talked to so many of you, even over the course of today, about the needs of our specific patient population. And that can be really, really different. And that can tell us that being able to rapidly access our data, like we talked about at the beginning of the talk, to be able to say, is this model going to work in our patients, needs to be something that we do really quickly and efficiently. This is an example. These are confusion matrices from how state-of-the-art models work in diagnosing nevi versus melanoma. Okay, I'm going to use my mouse pointer again. So basically what happens is these are the true labels. So how often a nevus is correctly diagnosed as a nevus. This is how often a melanoma is correctly diagnosed as a melanoma. You do not have to look more at this table. Here are some examples. So if you compare ulceration and no ulceration, we see that model performance will drop off. Ulcerated nevi, in areas of trauma, places where you might otherwise have had an ulceration, will be incorrectly diagnosed as a melanoma. This mouse disappeared 35% of the time. And the same with melanoma. So if you have an ulcerated lesion, the melanoma accuracy will increase and you'll see that more lesions are diagnosed as melanoma. This happens with pigmentation and no pigmentation. These are all things that we predict, as dermatologists. If it's not a pigmented lesion, it's going to be more difficult for us. For the model, it's the same. 24% of the time, it will diagnose a nevus as a basal cell. If it's not pigmented melanoma and it's erroneously diagnosed as a basal cell, that might not be as difficult for us. And then this is where I think this is the most important. So anything that starts with an S is a source in this table. So if you have a nevus from a specific source, Molmax, that does not have a lot of melanomas, state-of-the-art models will get that correct 94% of the time. But if you have a melanoma from that source, state-of-the-art models will think that that's a nevus because they have not seen that many melanomas from that source. Be that age distribution that that particular clinic has, maybe it's a specific camera type that that clinic has. We don't know what the model is learning from that distribution. And so, as a dermatologist, I don't want to be in that source that's getting all the melanomas wrong. I want to make sure that a model that I'm going to deploy in my clinic, in my patient population, in my teletriage is going to actually work for the patients that I'm going to actually see. And so that's something that I really want to highlight. We still don't know enough to know what exactly is fooling the models when they get things wrong. And that's going to be really important to our patients. And finally, when we talk about applications, so the application that I really want is for the patients that need to be seen, all these angry patients in the waiting room, to get seen by the person that they actually need to see. And that involves a lot of triage. And we need to make sure that those models are working well and the potential impacts on the whole healthcare team are evaluated. And, it really echoes what Shannon said in a little more detail with a few examples. So please check out the checklist. Please check out the large language model checklist that we talked about earlier in this session. And, please contact us if there's work that needs to be done. The thing I do want to say is, we spent all day talking about so many cool AI models, and thank you so much for our hosts for highlighting this. But almost none of them were we able to really dive into the details of all these questions that we've brought up in this session. And that's, due to time limitations. And it's also due to the fact that none of the off-the-shelf algorithms are required to go into that much detail by our regulators to help us answer these questions. And so we need to really demand that from the regulators, and we really need to demand that from the algorithm developers when we're thinking about buying things for our practice. And I know we're going to have a lot of time for questions, and I'm really excited about the discussion. But for right now, my takeaways from the session and from all of the speakers are model performance is likely to be overfit to specific situations and training conditions. Current best AI use cases in dermatology practice are not for diagnosis, although those get all the hype and they end up with us getting headlines that we're going to lose our jobs. Scheduling, we have infusion scheduling that's been deployed across lots of cancer centers. Those kind of examples are still closer to prime time. Patient privacy, and there's recent work on this in terms of apps. It's not standardized or well regulated. So if you're going to upload a patient photo into an app that you have on your phone, you have no way of knowing what is going to happen to that image. And that same is true for when a patient uploads a photo to those apps. We need to define the use cases very tightly. And for now, until regulators really step up to answer these questions that we're asking, we're going to need to make our own decisions for what to implement in our practice. And that's going to be major work. And I'm really glad that we've had this time today to really brainstorm, what do we need? What do we need the models to do? And what do we need to talk about amongst ourselves? And so thank you so much for having me.